As our next presentation will illustrate, MCubed projects are very impactful, even involving matters of life and death. This presentation contains sensitive material, but I think you will ultimately be heartened by this project's emphasis on human dignity. Titled High Stakes Decisions in the Pediatric ICU, A Better Way, this cube unites faculty members from the School of Nursing and the Medical School, as well as faculty and a graduate student from Psychology and LSA, and an undergraduate student from Cognitive Science and Economics in LSA. We'll now learn from Professors Cynthia Arslanian and Gorin and Kenneth Pediatric, and undergraduate student Rohini Majumdar.
Progress in pediatric intensive care over the last 40 years has enabled many, many children to survive from conditions that just a few decades ago were considered completely unsurvivable. Advances have led to many more children being able to make it through things that even when I was a medical student and intern were uniformly considered fatal. There's a downside for some of these children, however, in that when one part of their problem gets better, but they're still not able to breathe on their own, the physicians taking care of them and their parents are faced with a decision, what do we do next? And often the way forward is to place a plastic tube in the throat called a tracheotomy and to train the parents on the use of a home portable ventilator. Why this is something that can certainly be done with the hope in the future that the child will no longer at some point need the ventilator and even have the tracheostomy tube able to be removed. This is not always the outcome. And the new challenge arises, especially in those children for whom an underlying part of their problem is a severe abnormality of their brain or their nervous system. Some of these children will never be able to walk, to talk, to feed themselves, or to communicate. When this is the set of challenges in front, the decisions ahead are very daunting for physicians and parents. A common way that I have seen as both a participant and an observer in these situations is that the physician will present the situation to the parents and tell them, well, your child is going to need advanced technology like a tracheostomy and a ventilator in order to survive. But even more often, the situation is explained by the physician. Alternatives of prolonged survival on life support or a shorter survival without it are presented, and then the parents are asked the question, what do you want us to do? These are very, very difficult decisions for families to face, especially when they feel like the burden is on them. I want to share with you a particular case that I met 2 years ago. This is Avesta. She was diagnosed prenatally with a condition called Miller-Dieker syndrome, which predicts very abnormal development, frequent seizures, and frequent episodes of pneumonia and respiratory failure. I was asked to participate in a conversation in the ICU when Avesta was 1.5 years old, and the question of whether or not tracheostomy and ventilator support would be the best thing to do for her. I remember telling the attending physician in the ICU, please try not to tell the mother or ask the mother, what do you want us to do? Avesta's mother, Amal, is going to share her recollection of that conversation with us.
And you asked me this question, what do you want for her? You didn't say, what do you want us to do for her? You say, what do you want for your daughter? And I remember I told you, you are asking me very, very hard question. Because honestly, I want her, this is the truth, I want my baby to be comfortable. In the meantime, I don't want my baby to go. I want her to be with me. But for her to be with me, I know that she will have to go through ventilator every time. Because they were suggesting to do trach if we decide to put her on ventilator, then they say we're going to open her throat and put a trach, and they say no trach. So I was thinking, okay, what's mean for her to be comfortable is only to let her go.
The decision was made and accepted that the best thing to do was to take out the breathing tube. She went home on hospice, lived for 3 more months, and died comfortably in her mother's arms. Amal, her husband Sam, stay in touch with us and want us to do what we can to help other physicians learn how to make these decisions and accept these decisions in ways that are more comfortable. These are really tough situations for all parents, and we're not taught how to do this in our medical training. Shortly after my conversation with Avesta's mother, I was out walking my dog in our neighborhood and ran into my neighbor, Professor Patty Delden, and told her about this situation. Well, Patty's a research psychologist in the LSNA, and she had some good ideas, and that's what led to the formation of our cube. Cynthia Arslanian-Angoran and Frank Yates and Sandy Graham-Berman are the senior members of this cube, and we were joined shortly thereafter by Drs. Laura Metzler and Dr. Stephanie Kukora, who are physicians that work in our pediatric intensive care units, and also by grad student Hao Young Yan and undergraduate Rohini Majumdar, who's going to continue the story.
I feel very fortunate to be a part of this cube, especially as a junior here at the university. In fact, Michigan's encouragement of undergraduate research is one of the reasons I chose to come here, and I'm really happy with my decision. So across all of our projects, we have been using the cardinal issues perspective, which is a decision framework developed actually by one of our CUBE members, Dr. Frank Yates, who is a professor both with the psychology department and also the Ross School of Business. We found a bunch of things across all our studies. I'm going to share with you some of the more important ones. And one of these things is that parents tend to be a lot more decisive when their conversations with physicians include discussion of their own personal goals and values. When we exclude such discussion from these conversations, they actually really struggle to arrive at these life and death decisions for their children. This is both because these circumstances are often very medically complex, but also just because these decisions are really high stakes, because we're talking about their babies' lives, and then some of these babies, as you saw, are often only a few weeks old. The next thing we've learned is that there's actually a discrepancy between what parents think will help them arrive at a good decision versus the kind of communication with parents and physicians that will actually help them to arrive at the best decision, which is one that not only serves their needs and goals the best, but also one that, and this is a priority for us as a CUBE, one that they do not regret in the future. And finally, probably the most important thing that we've learned is the role of language in such settings. So language and the words that physicians may choose to communicate these issues can alter not only the decisions that parents make, but also the satisfaction that they feel regarding those decisions. And so what that means is that language and clarity in communication in this field of shared medical decision-making is really crucial. Dr. Agee.
Thank you. As a team, we are excited about the implications of this work for education, for research, for policy, for practice, and for our patients. Currently at the Vanderbilt Children's Hospital, Dr. Pediatric has been invited to help develop an online curriculum to help intensive care physicians who treat seriously ill children learn the basic principles of shared decision-making. This approach, based on our research, emphasizes asking parents about their hopes, their worries, and how they can be better parents. This curriculum is currently being taught and evaluated in both Nashville and here in Ann Arbor. The next step on our research path is to conduct a qualitative study to better understand the decision-making processes of parents who are considering a tracheotomy intervention for their children. We are also interested in learning more about how physicians perceive or believe they communicate that information to parents. Our goal is to improve parent-physician communication so that parents can make the best possible decision for their children. Empirical findings from this work may inform critical care practice guidelines as well as patient-centered care policies. Indeed, the use of a shared decision-making, values-guided approach may even transform critical care practice. But most importantly, and arguably the most rewarding aspect of this work, is for its potential to reduce decisional regret, burden, and moral distress in both parents and providers. We believe by using a shared decision-making, values-guided approach, we can change a morally burdensome decision-making process into one that is more emotionally satisfying, even when the outcomes are less than desirable and indeed very, very sad. We believe we owe that to our patients and their families. Thank you.